We continue to our second lecture on the series of consent for surgical cases and procedures. When is it that a patient is deemed to be unable to give consent? There are 4 scenarios, that the law and the practice of medicine recognizes a patient as being unable to give consent. First one is when the patient lacks capacity by virtue of mental retardation, psychosis, or decompensated comorbidities, and you have significant altered mentation, either permanent, like in the patients who have mental retardation, or temporary, as with the patient who develops psychosis, or who have decompensated comorbidities that have altered their mentation. So a patient in diabetic ketoacidotic coma, a patient who is having acute psychosis from some poisoning is unable to give consent. Secondly, you have patients who have altered mental status by virtue not of psychosis, but by the level of their consciousness. So either they're semi-comatose or they're unconscious. These are also patients who are deemed not to be able to give consent. Thirdly, are patients who have injuries or lesions in the brain. In this scenario, it is any injury or any lesion to the brain, even where the patient's understanding seems to be retained. So then you also have to deem the patient as being unable to give consent. And the fourth one is when the patient is a minor. We will address a little about the patients who have injuries or lesions to the brain and those who are minors when you're going to talk about assent. Where a patient is unable to give consent, who by law and by practice of medicine is allowed to give consent by them? For one, it is parents if the patient is legally a minor. Please note the use of legally a minor because this excludes the emancipated minors. Okay? If a minor has been self-reliant, is the breadwinner for himself, lives and resides on his own, is raising a family of his own, then that minor is considered to be an emancipated minor, and the law allows them actually to give their own consent. Secondly, a spouse, if this spouse is legally recognized to be married. So it doesn't have to be a church wedding or an AGs, but where the law would have recognized this person as a spouse. And there are many other recognitions apart from the legal certificate. This would be community recognition, cohabiting for a certain duration of time, recognized by marriage. All these ones would be persons who would be allowed by law to sign on behalf of the patient. The third one are people who we term as healthcare surrogates. So if the healthcare needs of a certain patient are met exclusively by a certain individual, and this patient at the time of presenting is not in a position to give consent by virtue of the 4 reasons we saw in the preceding slide, then this healthcare surrogate is allowed to give consent for them. At times, patients do get to appoint their proxies, or like in the 5th case here, to give the power of attorney to certain persons while they're still of sound mind, and then they get to deteriorate, or they get to age, and then at such a point, if you need consent from procedure or intervention, you'd have to turn that to their legally appointed proxies or their attorneys. Are there emergencies that the doctor can sign? Yes, but the 4 criteria have to be met. 1, the patient must meet the criteria we discussed 2 slides ago. Second, there must be no other person who could have been authorized as the surrogate for the patient. So there's no next of kin and there's no authorized surrogate. In terms of next of kin, there's an order. Okay? So the patient's spouse is the first next of kin, then the patient's children follow after that, then the patient's parents follow after that. So a patient's parents cannot overrule what the patient's children who are not minors have consented for. So if, say, a 50-year-old female comes and is following a road traffic accident, is comatose, and then his 20-year-old child comes and the 70-year-old mother comes, the consent will be requested from the 20-year-old child. Okay, so but in the absence of that, then the doctor can sign. Third thing is that the doctor must be recognized by the medical practitioners and dentist board and must be registered as a specialist. So two things have to stand in. First, they must be on the board. They must be on the roll of the doctors who are recognized by the medical practitioners and dentist board or council, and they must be registered as specialists, not as general practitioners. And then fourthly, once the doctor has consented for the patient in the emergency scenario, the doctor cannot be the one undertaking the specific intervention. In the practice of medicine, there is the understanding of assent. Assent is offered by minors in two scenarios. One, when the patient is legally not allowed to consent but has full or minimally diminished capacity to comprehend. Okay. This covers in two groups of people. One are minors above the age of 12 years, okay, but who have not reached the age of consent. So as much as they would have to assent for the procedure first, after their assent, you'd have to get the consent from somebody who is legally recognized as an adult. Secondly, patients who have any form of head injury or brain tumors, even when they have minimally diminished capacity or they fully comprehend what is happening, okay, they will assent, but the signature that will be appended on the consent document has to be from somebody who the law and the practice of medicine recognize to be able to consent. Yeah. The second group of times where the patient seeks assent, then you get consent from someone else, are where the patient comprehends fully, yeah, would wish to consent, but would also wish to have the involvement of the healthcare surrogate. This is more common, one amongst spouses, where a husband would say, asking my wife to sign for me, or my wife is asking that I'd like my husband to sign for me. Or sometimes when a parent is brought by the child who is meeting all the bills, is going to cater for all the things, then the parent might ask, the elderly parent might ask, I would ask if one of my children is the one who signs for it. In such scenarios, you must always document the assent before you get the consent. And where you're going to document the consent, you must indicate why the consent is not from the patient. Okay. If it's a minor, you'll indicate that it's a minor. If the patient has a brain tumor or a brain lesion, you indicate that the patient is human. Okay. So the assent might be documented in the patient's notes, but the consent is now documented on the approved consent forms. Can the patient decline to consent? Yes. And we add, even at the point of death, as long as they have full mental capacity and have understood the information that you passed on to them. Usually, we would ask you to give a little time for the patient to think, and then you come back, explain it again, and ask the patient to explain it in their own words. If they are able to explain to you in their own words, and the patient still holds back their consent, then this is a decline of consent, and it needs to be registered with a decline of consent. Legally, you cannot turn to the patient's surrogate unless if the patient's capacity is in question. And where the patient's capacity is in question, you must have another specialist who was not involved in the initial seeking of the consent to come evaluate the patient's capacity and document that he or she concurs with the first team that the patient's capacity is in question. Okay. Why it is allowed to be a specialist is that best of all, you would wish to have a psychiatrist or psychologist, but sometimes the capacity is not psychological or psychiatric in origin. Then in that case, a specialist of the defined specialty is allowed to come in, evaluate the patient, and say that yes, in my opinion, as a specialist, the patient's capacity is deterred by 1, 2, 3, and the patient is not in a position to give consent or not. Okay? But where the patient has full mental capacity, full physiological capacity, and declines to give consent, this is not an equivalent to decline of medical care. Okay. So where there are alternatives that can be offered, the medical care, these must be discussed and commenced and progressed until such a point that either you get the consent or the patient no longer requires the intervention or procedure that is done. Always document and always validate the decline of consent. Are there times that you can conduct a procedure without the patient's consent? Yes, there are 5 scenarios where the patient's consent is not required. 1, there is examination of persons at ports of entry. They be it a seaport, an airport, a land port, a border post. In most Commonwealth countries, their laws have provision for examinations of persons at port of entry without their consent. Second is examinations of people for notifiable diseases. Yeah, this one in Kenya is covered in the Public Health Act, Cap 242, as amended in the 2019, if I'm not wrong. Yeah, so where there is provision to have, as let me give the example of the currently we have we're undergoing a pandemic of the COVID SARS-2 virus that has been with us now for a few months, and you are a patient who was presented to a healthcare facility with signs and symptoms that may be considered to be indicative of COVID SARS-2. In this point, should the institution to which you are presented find it necessary or find that there's a possibility that you may be suffering from this particular disease, then the Public Health Act allows them to proceed and do for you that examination. Okay? Third scenario is routine examinations for members of the armed forces. Okay? The laws of Kenya allow them to undergo several structured examinations by virtue of finding their fitness to continue serving the armed forces. And for these ones, they usually do not consent. Declining consent is tantamount to turning, going against the provisions of the armed forces. Fourth is examinations of psychiatric patients prior to admission to first and foremost to general units. If a patient is known to be a psychiatric patient and requires to be admitted to the surgical ward, the medical ward, the obstetric and gynecology ward, and the team there would wish to have them undergo psychiatric examination, then that examination does not require the patient or their next of kin's consent. The same occurs where the patient comes into the admitted to a general unit with other indications, and then there is cause to think that the patient might be having underlying psychiatric conditions that may prove to that may adversely affect their management or in fact affect the management of other patients in the unit, then they need to undergo psychiatric evaluation. And the fifth one is examination of prisoners at point of admissions into the prisons. Sometimes also where there are public health interventions being done, then refusal to subscribe to those interventions are considered to be a breach of the Public Health Act. So these ones usually do not require your consent, what they require is for the provider, for the patient, for the client to be enlightened on the benefits, the possible risks, and possible adverse outcomes that may come in. And this one goes for health interventions like immunizations, the need to isolate or quarantine certain populations, the placements of travel restrictions, and restrictions to individuals when they move from one point to another point. And the last point when consent is not necessary is where the court of competent jurisdictions ordered certain care interventions on a person. There are times when the law allows for override of a decline of care. So one, if a minor is below the age of 12 years and one parent declines care and the other parent consents, then the consent of the patient's parent who was consented is taken to run supreme. And you can be allowed to continue to provide interventions or provide surgical care for such patients. Yeah. But they must be parents, or both of them must be legal guardians. It cannot be a healthcare surrogate. So the aunt who is paying the bill for the patient, if the mother of the patient has declined to have the patient operated, the aunt cannot be the one that consents for you. Okay. Secondly, is if when the minor is below the age of 12, has declined to assent, then only during emergency care can the guardian consent. Please remember that this guardian, in this scenario, the guardian is consenting for emergency care, not elective. So if the child or the girl is 13 years, 14 years, it has a umbilical hernia, comes in with the mother, and the child says, I don't want to have this hernia operated, yeah, then you cannot take the mother's word and operate on the child. But if the hernia is obstructed or strangulated and the child is 16 and she has declined and the mother comes and says, I consent, then you as a healthcare provider is allowed to proceed. Okay. There are times when the healthcare provider is tempted to try and change the patient's decision. Please note that this is not allowed. What you should try to do is one, strive to improve their understanding of their condition, the benefits, the indications for the procedure, and the benefits that withstand them. Where you can, bring on board family members, bring on board friends, bring on board surrogates to talk. But please remember, these family members and friends are those who had initially been brought on board and were conversant with the care of the patient prior to that. So you cannot call the patient's grandfather from 300 kilometers away to come and talk to the patient. Okay, please. And lastly, as much as possible within medical ethics, you respect the culture of the patient and the population in which you're practicing. Because some things might not be permissible by culture, so you would have to get alternative interventions and way for intervening for that population or that individual in person. Thank you.